Thank you very much for asking me to talk about transcranial Doppler screening in children with sickle cell disease. I'm actually a clinician. I'm a paediatric neurologist in Southampton, as well as having an academic appointment at UCL. Next slide, please. I would like to just acknowledge that this is really a collaboration across the National Health Service, particularly in London, and also including St Mary's Hospital and the other hospitals in North West London that took part in the study under Roberts. And continuing with Sabana and the team with Kristen and Josu. Next slide, please. One of the important facts to know about children with sickle cell disease is that the stroke risk is very high in the young child. We don't really understand why, but the peak risk is actually in preschool and primary school age children. The risk of infarctive stroke, the yellow line, then falls in young adulthood, but there is a risk of hemorrhagic stroke in that population. This is data from the cooperative study of sickle cell disease published in 1998, but this holds true for the UK as well. Then in middle age, the risk of ischemic stroke goes up and may well be somewhat similar to the stroke risk in the elderly adult just brought forward. Next slide, please. Now, there are a number of acute neurological syndromes in sickle cell disease. What transcranial Doppler is supposed to be doing is to be preventing symptomatic or overt stroke. There's no evidence that it actually prevents silent infarction. I can talk a little bit about that, but it's potentially largely a different pathology. And there are other acute syndromes: reversible ischemic neurological deficit, transient ischemic attacks, seizures, coma, which may occur despite transcranial Doppler screening. Slide, please. So this is an example of a large middle cerebral territory stroke in a 9-year-old girl who was really well, so wasn't coming to clinic very much. She was top of the class, and the left-hand MRI scan shows a very large infarct, and the right side of the slide shows that the middle cerebral artery on that side is completely occluded. We don't know whether that was because an embolus passed up to the middle cerebral artery, possibly from the pelvic or leg veins, or whether there was a severe stenosis beforehand. But you can see that it's definitely the cerebral artery that's involved. Next slide, please. Now, you'll actually know a little bit about the Doppler. You may not think you do, but you do, because it's actually the reason that you can hear the pitch of the whistle of a train coming towards you, changing as it comes and goes past you. Next slide, please. So Christian Doppler was actually an astronomer who looked at the velocity of moving stars, and he described the Doppler frequency, which is related to the incident frequency of whatever you're looking at, in this case sound, which is related to the frequency of the Doppler shift by an equation that includes cos theta, which is the angle for the transcranial Doppler between the vessel and the probe. The important thing about the Doppler, the transcranial Doppler, is that the angle between the vessel and the probe is actually very small, and so cos theta is 1, and that means it goes out of the equation. So that we can actually use the Doppler shift to measure velocity directly. However, it's important to emphasize that we're not actually measuring flow. We are measuring velocity, and the relationship between flow Q and velocity is described by an equation which also includes pi, which I'm sure you'll remember from your school days is 3.14 and many, many decimal points, and r squared, which is the radius of the velocity of the vessel squared. So that's quite a big component. Next slide, please. So this is how we actually obtain a signal. We're using the probe on the side of the head just in front of the ear, and we're looking at the middle cerebral artery on the right hand side, and we can also see the distal internal carotid artery as it comes in and bifurcates into the anterior cerebral artery and the middle cerebral artery. We can look at the posterior cerebral artery as well, and that's part of the UK protocol, but the data are not as useful as, and the tendency recently has been to focus on the middle cerebral and the distal internal carotid arteries. Next slide, please. We can't tell whether, if we see a high velocity, whether that is actually related to the increased cerebral blood flow that we know that children with sickle cell disease have. And on the left is a scan, a PET scan showing the high flow, the red, in a child with sickle cell disease compared with a normal control where the red is much less. Because of the relationship between Q, the flow, and velocity, we could be seeing very high flow, or we could be seeing a narrow vessel, as is shown on the right hand side. We don't know, although if there's symmetry, then we would have a hunch that this is global increase in cerebral blood flow, whereas if there's significant asymmetry, we would be thinking there's probably cerebrovascular disease. Next slide, please. And this actually shows Robert Adams, who originally described using transcranial Doppler in children with sickle cell disease, undertaking a scan in his own son, who is now well into his 40s, and is given permission for this slide to be shown. So it's actually quite easy to get signals in young children, and an average study in a child between about 4 and 12 will usually take a few minutes, maybe 20 minutes. In younger children, I always get the nursery nurses or play leaders to distract the child, as I would do for a hearing test. And in the older children, the bone can sometimes be a little bit thicker, and we have to spend more time trying to find a decent bony window. Slide, please. So Dr. Adams actually described a number of thresholds. You can see that the thresholds between 70 and 150 on this slide predicts low risk, particularly if an accompanying MR angiogram is normal. There's a potentially increased risk between 150 and 200, and he later defined a cutoff of 170 centimeters per second as being conditional, and if you have a velocity between 170 and 200 in his 1997 study, you had a 7% risk of having a stroke over the next 3 years. However, if you had a velocity over 200 centimeters per second, then you had a 40% of risk of having a stroke in the next 3 years, and that risk increased the higher the velocity, and particularly if you had an abnormal MR angiogram. With very low velocities, the data are not so clear. Quite a lot of people, children with low velocities, have already had a stroke, but they also may have a poor bony window, and we usually don't know, and it's usually useful to have an MR angiogram in those studies, in those cases. Next slide, please. So this is me doing a transcranial Doppler in the girl with a stroke. You can see that actually she's holding her hand. That's because she's had a right hemiparesis. Again, I have permission to show this slide. And you can see that we're getting signals on a rather old-fashioned computer there. Next slide, please. This is what we can actually see. On the left-hand side is the velocity from the right MCA. We're looking at it as we would do from CT imaging or MRI imaging, so the right is always on the left. You can see there that the time averaged mean of the maximum velocity, which is, there's a black line on top of that uh, signal, and that is measuring the time average maximum mean velocity, and it's 200 centimeters per second. You do not want to be looking at the systolic velocity, which is the bottom at 259. You're wanting the mean at 200. On the left-hand side is a conditional velocity at 182 centimeters per second in the mean, so that would predict a stroke risk of 7%. Next slide, please. There are some caveats. We do need to have the child calm, and we don't want the child in particular hyperventilating, because as you can see from the right-hand panels here, if you hyperventilate, your velocity goes down, and if you hold your breath, then your velocity goes up, and that's actually turned out to be quite useful in a number of situations. There's some data suggesting that females have higher velocities, but we didn't find that in our data. But in the lower left-hand panel, you can see why this is useful in sickle cell disease, because we do see higher velocities with lower hemoglobins. Next slide, please. And this is normal range data that Charles Newton and I collected in Kilifi in Kenya. You can see that we had a cutoff of, in fact, 142 centimeters per second in children who had a hemoglobin of over 4 grams per deciliter. Now, the children who have the higher velocities in this study had been screened for sickle cell disease and didn't have it, but they were very, very iron deficient. So, to my mind, the cutoff for being within the normal range, even if you're a little bit anemic for another reason other than sickle cell disease, is probably somewhere between 140 and 150 centimeters per second. But the children with velocities between 150 and 170 are still currently considered low risk, and I think that's reasonable, although I do think they need following. Next slide, please. So why does this matter? Well, it matters because there's considerable evidence that if we screen and treat children with abnormally high velocities over 200 centimeters per second, then we can very substantially reduce the stroke risk. So the STOP trial randomized 130 children with two transcranial Dopplers showing maximum time average mean of the ICA or MCA velocity over 200 centimeters per second to either blood transfusion or no treatment. And this is the sort of randomized trial that everyone would have liked to have been the principal investigator on, because there's a 92% risk reduction, very highly significant. And that, of course, is the mainstay of management and has been since 1998 when STOP 1 was published. Next slide, please. This data is from STOP 2, which was published in 2005, and the slide was made up by Michael DeBowen for the American Society of Hematology Guidelines for Sickle Cell Disease. And you can see that if you continue transfusion beyond the end of the study, then your stroke risk you didn't have a stroke, basically. Your stroke risk was 0. Whereas those randomized in STOP 2 to discontinuing treatment actually had quite a high ongoing stroke risk. So the message of this study, the STOP 1 and STOP 2 studies, was that you need lifelong transfusion to prevent stroke in children with an abnormally high velocity. Next slide, please. However, in the interim, more and more children have been offered hydroxyurea. And there's clear evidence that using hydroxyurea actually reduces the risk of, reduces the velocity, and this is data again published from the American Society of Hematology guidelines, and you can see that the vast majority of studies have shown a considerable reduction in transcranial Doppler velocities with hydroxyurea. Next slide, please. We also can look at the evidence from the Twitch trial, which was run mainly in the US, and that was a trial randomizing children with an abnormal velocity who'd had 1 year of blood transfusion and had a normal MR angiogram. And I really must emphasize that very strongly. So this is probably children with the high blood flow secondary to the anemia. They were randomized after 1 year of blood transfusion to either ongoing blood transfusion or switching to hydroxyurea. And it was a non-inferiority trial with transcranial Doppler as the main endpoint. And you can see here that there was no statistically significant difference in the transcranial Doppler velocity over 2 years between carrying on with blood transfusion and switching to hydroxyurea. Next slide, please. And this is that's actually the actual data, and in fact there was a post hoc analysis for superiority, and hydroxyurea was statistically significantly superior in the post hoc analysis. Next slide, please. Now, I've already said that it's incredibly important that for Twitch that we know what the whether there is actually vascular stenosis or whether this is probably high blood flow. And this is some data that Dawn and I have been working on for a number of years, looking at grading the arteriopathies in sickle cell disease. The top left, the 0 is a normal MR angiogram. Then you can see there's grade 1, which we're actually not looking at the structure of the vessel wall. This is turbulence in the vessel caused by the high velocities. That could be said to be within normal limits, and many neuroradiologists have reported as normal. It's early days, but just saying that we have seen abnormal brain microstructure. If you want to look that up, it's Mboka Jacobs' paper from Tanzania. And I'm not convinced that grade 1 turbulence is actually consistent with complete normality. But you can also see that in grade 2 turbulence, there's definitely some narrowing or abnormal flow in the vessel, and then grade 3, there's complete occlusion. I can actually see some very faint collaterals on that, but as Dawn will tell you now, there's a grade 4, which is frank collaterals. Next slide, please. So, hydroxyurea for those who have high velocities and a normal MR angiogram. There are 2 new studies from northern Nigeria, the teams in Kano and Kaduna, led by Dr. Balamanga in Kaduna and Dr. Abdul Hai in Kano, and ably supported by Michael DeBan from the US and funding from NIH. This shows data from the feasibility study, which again shows consistent reduction in transcranial Doppler velocities from screening to 3 months, and then again to 2 years. Again, consistent with the previous data, suggesting that velocities were going down with hydroxyurea. Next slide, please. The and this is data from a study that I was involved with, which actually randomized children in northern Nigeria to either moderate dose hydroxyurea, which was 20 milligrams per kilogram, or low dose hydroxyurea, which was 10 milligrams per kilogram. We did not have ethics for a placebo, which I think was the right thing to do. And we thought that 10 milligrams per kilogram would not be enough. But in fact, for reducing transcranial Doppler velocities, as you can see, there's no statistically significant difference between those two doses of hydroxyurea in this study, the spring study, which was published in Lancet Haematology in 2022. Importantly, the dose of hydroxyurea in that study did matter for reduction of pain. The reduction of pain was better at 20 milligrams per kilogram. In the US and Europe and the UK, we do tend to suggest hydroxyurea to maximum tolerated dose, but in developing countries, it is reasonable to use a dose of either 10 or 20 milligrams per kilogram if you want to reduce the TCD velocities, and it does mean much less monitoring of white cells. And I would just mention that Sam Greer, who I work with, who's in Nairobi, when asked whether he would rather have hydroxyurea, which is still too expensive to be bought across Africa, if he'd rather have the hydroxyurea or TCD screening, he said he'd rather have the hydroxyurea for everybody, please. Next slide, please. Next slide, please. So the stroke guidelines in the UK suggest that children should be screened yearly from the age of 12 months for abnormal velocities. I think actually the haematology guidelines are from 2 years. I have done a few under 2 years, and I'm always willing to have a go, but I would definitely want the play leader. Children and the guidelines state that those with velocities over 200 centimeters per second should be offered long-term transfusion. I think nowadays, after Twitch, many are offered transfusion for 1 year and then hydroxyurea, provided the MR angiogram is normal. Next slide, please. And this just shows data from London. We actually had a lower prevalence of high velocities in the 1990s and 2000s. This is data from the East London cohort that I was screening in that era, whereas in the US, people were seeing 10% abnormality in the screening for the STOP study. We were seeing 5%. And we were seeing another 5% conditional. Nowadays, in the US, the prevalence from Julie Cantor's most recent data has gone down to between 2 and 3%. And in the 5 years I've been doing clinics at UCLH, I've only seen my first abnormal TCD in January 2023. So I think that the more prevalent use of hydroxyurea and perhaps better general care has improved, has reduced the prevalence of high transcranial Dopplers, but nevertheless, we do need to carry on screening. Next slide, please. And again, just returning to my earlier point, this is from the East London cohort that I collaborated with Paul Telfer on, 275 transcranial Dopplers in 124 children, as managing to screen 80% of those over 3 years. And we found 6% abnormal going on a bit longer than I had. And one of the ones that I diagnosed in 1992, and this was an observational study before the STOP trial published, that child had strokes. And 2 had already had an infarct when they were first screened, and 4 were transfused as primary prophylaxis and had no stroke. However, 4 children had an overt stroke despite a standard risk transcranial Doppler. And you could say that maybe we missed something, or you could say that what we're actually doing is screening intracranial for intracranial vasculopathy, which is common in young children, and for high cerebral blood flow, which is common in young children. However, things are a little bit more complicated than that, and we certainly see other pathologies. Next slide, please. Uh, the other thing that I think is worth saying is that it's unusual to have high velocities in children with hemoglobin SC disease. But again, I have seen 1 or 2 children with hemoglobin SC disease who've had a stroke, particularly one child I can remember who had a stroke after trauma and may have had a dissection, and another adult with SC who in his mid-30s had a stroke and had terrible sleep apnea. So there are other risk factors for stroke other than just having a high TCD. We don't screen the adults because they don't tend to have such high velocities, and there's no evidence that screening them actually reduces stroke risk. Next slide, please. And similarly for hemoglobin S thalassemia, either beta plus or beta 0, we undertook a study with Demetrios Safiriou in Thessaloniki, and we did not find any velocities over 200 centimeters per second. And again, across London, I have actually at UCLH continued to screen patients with hemoglobin S beta thalassemia, and I have found an occasional stenosis in this group, but it's relatively rare, and we screen them every 2 years rather than every year. Next slide, please. So this is the chart looking at what to do. Basically, if your velocity is less than 170 centimeters at screening, we restudy in a year. If it's abnormal twice, then we restudy. Once and then begin transfusion, although if it's over 220 centimeters per second, we usually begin transfusion immediately. If it's conditional, low conditional, being 170 to 184 centimeters per second, we restudy at 4 months and continue to follow. If it's unchanged, and high conditional, we would suggest restudying at 2 weeks and then seeing again at 6 months if the velocity has not gone into the abnormal range at 2 weeks. Next slide, please. And this is a very similar study for the older children between 6 and 10 years. Next slide, please. Now, is this important? Does it work? The answer is yes. This is a review that Iki Lugunju from Ibadan in Nigeria and I wrote in 2021. On the left is the data for strokes per 100 patient years of observation, going right back to the original POWER study from 1960s to the 1970s, and including Iki Lugunju's data from Nigeria towards the bottom, which has a very high incidence of stroke in unscreened and untreated patients. And at the bottom, you can see overall, Professor Lugunju has reduced her incidence by screening with TCD and giving hydroxyurea. On the right-hand panel, this is looking at the detail, looking at children with transcranial Doppler velocity over 200 centimeters per second. From my study, 1990 to 1998, Lugunju study 2004 to 2012, and Robert Adams untreated patients up to 1997. These are children that were in the STOP trial. And then looking at Adams transfused patients, 1995 to 1999 in the STOP trial, you can see that if you've got TCD velocities over 200 centimeters per second, if you're transfused, the number of strokes per 100 patient years of observation goes down from 10 to 15 to about 1. And I'm delighted to say that that is also true for the use of hydroxyurea, which is in many ways easier to do. That's true for the Gulbis data from Belgium, and also from 2 studies from Africa, Galadanci 2014 to 2019. Again, another feasibility study, and Ikigunju's data from Ibadan, 2009 to 2019. Next slide, please. I was asked a question about low velocities, and this is just to show our data looking at middle cerebral artery velocity on the y-axis in the left middle cerebral, and grade of turbulence, which I showed you the pictures of earlier. And you can see that the patients with the velocities less than 50 centimeters per second, some of them did have vasculopathy. They actually they come into the particularly into grades 3 and 4, and there are also some patients that we could not get a signal in, so they came out as 0 in all 4 grades of turbulence. However, some of these children had a normal MR angiogram, which just means that we didn't have a good enough window to get a signal. But we are, my usual advice is, if we are having difficulty in getting clear signals, that we do an MR image and an MR angiogram so that we really know what we're doing, and that we do actually include the extracranial vessels as well as the intracranial vessels. Thank you very much.
So usually when children get to see a neuroradiologist, well, they've often had a stroke, or they're being screened because their velocity in the middle cerebral artery is found to be high, or, as Fenella talked about, in twitch, when we had a case recently where the child was trying to be moved from being on transfusion onto hydroxyurea, and we were involved in the imaging in relation to that, looking for a normal MR angiogram before that could be done. But I thought I'd just talk a little bit about stroke and sickle cell disease and what they look like compared to other conditions. They're often cortically based, and when you have a cortical infarct, they're usually secondary to large vessel disease. So it's important that these children have an MRA, intracranial MRA as well, and ideally also an extracranial MRA. Often we see small white matter lesions, and they are in the watershed distribution very often, but even though they're in the watershed distribution, they can be due to small vessel disease and not large vessel disease. And sometimes they're also periventricular. And 10% of children with sickle cell anemia and silent infarcts go on to develop symptomatic cerebral vasculopathy, or certainly this was the data prior to bone marrow transplantation, which does modify the vasculopathy. And as Fenella said, young children, children are screened with TCD to try and prevent these strokes and identify the vasculopathy. So this is a case of a child with an arterial ischemic stroke, which is in the watershed distribution, which is quite typical distribution. It's cortically based. You can see the watershed is the yellow arrows. And in the picture at the bottom on the left-hand side, the anterior circulation is divided into the green, which is the anterior cerebral artery distribution, and the red vessels, which are the middle cerebral artery distribution. And between that, you can see those lines are the watershed, and we can see that that's often the area of infarction. Now, sometimes we see watershed distribution when there's a stenosis of the large vessels, typically the terminal internal carotid artery, which divides to supply the anterior and the middle cerebral arteries. But sometimes we also see, and that's a hemodynamic infarction, but we can also see this distribution in children without large vessel vasculopathy, and due to small vessel disease, we have seen that. So I'm showing you here images of periventricular silent infarcts. These are the infarcts that we identify in children and who are at further risk of strokes. And they're called silent infarctions because they don't present with neurological abnormalities. They just are picked up as part of screening, or if the child scanned for another reason. And they're often periventricular, as you can see in the middle image of the two yellow arrows, or a little bit more peripheral. And there's a very strict criteria that's set out by the SIP trial in terms of what exactly a silent infarct is. And it has to measure more than 3 millimeters in two planes on a T2 weighted image. And if it's smaller than that, it's often just as considered to be unknown, something that we don't understand. This is some work that was done on a cohort of African patients looking at the, it's called the heat map, the distribution of silent infarcts, and where the heat is, it's hard to, without a pointer actually, but if you look at the patients on the top compared to the control, you can see that sometimes we do see these small dots. We see them in childhood, and we see them much more in adults as well, in the context of small vessel disease, but we often see them also following infection. They can be very non-specific. But in sickle cell disease, we see many more of them, and the heat map shows, so the patient, the left-hand image, you can see the orbits at the bottom of the image, so you're looking towards the head, and it's a 3-dimensional image, but you can see that a lot of those very bright infarcts, as they are, represent the watershed distribution in the deep white matter. And that seems to be where the propensity for these silent infarcts is. This is a young adult who is 19 with sickle cell disease and a stable vasculopathy. And in image A, you can see a relatively normal middle cerebral artery, and then on the left, a narrow middle cerebral artery, and the anterior cerebral arteries, which are at 12 o'clock going north, are well seen. And then on image B, a year later, the child or the adult presented with acute confusion and disorientation and had an infarct in the middle cerebral artery territory, and the vasculopathy had deteriorated despite the patient being treated with transfusions. And the image C is a diffusion weighted image, which is particularly sensitive to the identification of cerebral infarction. And on the right of the image, there's a very bright area in the middle cerebral artery territory, which is that infarct. Now, some children with sickle-related vasculopathies go on to form abnormalities that are diagnosed as Moyamoya Syndrome. And these are an occlusive vasculopathy with collaterals. And these collaterals, when you do a cerebral angiogram, look like a puff of smoke. And Moyamoya is Japanese for puff of smoke, which is how that name comes up. Now, one of the reasons that hemorrhage is seen more commonly in adults is that these Moyamoya collaterals bleed more regularly than normal vessels, and so these children sometimes get vascular hemorrhages, but that's not the only reason. There are other reasons that children present or adults present with hemorrhagic stroke. And these children are candidates for revascularization, particularly if they've got very severe disease bilaterally. And this is a patient with Moyamoya, and you can see that the child has multiple what we would probably have considered as to be silent infarcts on the top left image, and then develops a large cortical infarct involving the middle cerebral artery territory on the middle top line image. So all that white area, high signal, is restricted diffusion, and on the top right hand image you could see it